Ludwig's angina is a true emergency because of the risk of airway compromise. This is more of a zebra diagnosis, which is exactly what makes it pimp-worthy, especially during your infectious disease rotation. What is it? It's a cellulitis of the floor of the mouth, not an abscess. The concern is that it can evolve quickly, if not properly diagnosed. Patients typically present with a bull neck appearance, trismus, dental pain, or even tongue elevation. The infection is usually linked to dental infections or decay. This is why you should always encourage good dental hygiene in your patients. Diagnosis is made with a CT neck with contrast. Of course, check a CBC and get blood cultures. So, how is this treated? Always be ready to support the airway first. Ludwig's can lead to swelling of the submandibular and sublingual spaces, making it difficult to breathe, swallow, or speak. There is a risk for complete airway obstruction. Intubation or even an emergent tracheostomy may be necessary, so keep a low threshold for involving anesthesiology or ENT early. Start with broad-spectrum IV antibiotics. Administer an IV steroid bolus to reduce swelling and consult ENT for surgical drainage if there is an abscess or worsening symptoms. Also, consider consulting infectious disease if the patient has a concerning history.